Thank you for spending your time with us today. And just kind of the basic disclaimer, everything is current as of today. That doesn't mean that by tomorrow there won't be changes, because you can almost guarantee for some things there will be. But we'll talk about those as we go along. And so today we're going to discuss some of the major highlights of the 2022 Medicare Physician Fee Schedule final rule. And it would help if I hit the page down. All right. So we'll talk about the evaluation and management visit updates, and that's specifically we'll be talking about the shared or split visit updates. We'll talk about telehealth services. There are some updates to reporting therapy services, and that's not only like the occupational therapy and physical therapy, but we'll also be doing some medical nutrition therapy in there as well. There are some updates to physician assistant direct billing and the colorectal cancer screening. There are some changes to the deductible and how that's going to work. There is going to be an update kind of phased in for the electronic prescribing of controlled substances, which most folks already do. There are a couple of updates to the appropriate use criteria, but not a whole bunch, so nothing super major in there. And then we'll touch on the pulmonary rehabilitation updates, talk about some drug pricing and payment information. And then I added a miscellaneous section just to kind of capture some things. For example, there was some legislation passed last Friday that will affect like the sequestration adjustments that are taking place. So that's part of the stuff that's going to be changing, that where we can do some updates. And I keep hitting my page up instead of my page down because the buttons are opposite of what they are for my keyboard at home. All right, so for the E&M visit updates, so I just wanted to start out with some background information and kind of where it started. So the definition, kind of the conditions of the definitions for the services and supplies. These are incident to a physician's professional services. The non-institutional setting means all settings other than a hospital or skilled nursing facility, and that the Part B pays for those services and supplies that are furnished in a non-institutional setting to non-institutional patients. So that means other settings other than a hospital or skilled nursing facility. And I know what the questions are because I have some of those too. So in the final rule, what it said was that for visits furnished under similar circumstances in facility settings, for example, in a hospital, the current regulations provide for payment only to the physician or to the nurse, the non-physician practitioner who personally performs all elements of the service, and no payment is made for services furnished incident to the billing professional services. And so that kind of raised the red flag to me. I'm going, well, what about the provider-based departments of the hospital? And unfortunately, there's no really good answer to that question. And so hopefully some additional guidance will come out, because CMS has been stating that, for the provider-based departments, they are functioning as physician offices, and everybody has been doing the incident to services already. So my feeling is that they'll actually come out and say that that incident to in the provider-based department is okay. It's just when a patient is an inpatient. However, that information has not yet come out. And so in one of the other pages, as I'm reading, it says that the office visits will not be billable as split or shared visits. And so it's really no different from what's in the current practice. And they did state in the final rule that currently for office visits that are done as billable, or as, as split or shared, when you have two providers that are providing evaluation and management services, you usually combine those together and only bill for one. So really it's not supposed to be much different from what is in current practice, but of course it is. And so what CMS is stating is that they are kind of clarifying their longstanding policy, which really means they've kind of stirred it up and muddied it a little bit. And so they are stating they do not see a need for a split or shared visit billing in the office setting because the Incident to regulations govern situations where the like your NPP works with your physician who bills for the visit rather than billing under the NPP's own provider number. So you just have to make sure that that is working under the Incident to provisions that you're used to, where the physician starts the visit and the NPP is working in conjunction with the physician. So I'll start off the next slide. Nope, going backwards again. So I'm going to start off the next slide. There is a new modifier for the FS for a split or shared evaluation and management visit. And what CMS has then defined a split or shared visit, it's an E&M visit in the facility setting performed both by a physician and a non-physician practitioner who are in the same group. Group is not further defined at this time. So they did have some discussion on whether it's the same tax ID number, the group affiliation setting. They did not. So it's, if you're considered in a group now, they're just going with the current definition. And so it's also furnished in a facility setting, then that's defined as an institutional setting where Incident to billing is not allowed. So that's kind of where I'm taking my definition of the regulations as being inpatient, because the Incident to between the physician and non-physician, like your nurse practitioner or your physician assistant, is not allowed. And so what they're going with now is that this could be billed by either the physician or your NPP if it's furnished independently by one of them in the facility setting. And some more regulations that that go into play. So what CMS is saying now, it should be billed by the physician or the NPP who performed the substantive portion of the visit. And then to make things fun, they're kind of changing how it's done and phasing in, making some differences. So in 2022, that will be based on one or two things: the history, the physical exam, and the medical decision making, like the old E&M 3 levels there, or more than half of the total time. When we get to 2023, then it's going to be based on the more than half of the total time spent. It's going to include new or established patient visits, initial or subsequent visits, and prolonged services. And it does not include E&M visits like critical care, because we'll be going over the critical care stuff in a few more slides. And there are certain skilled nursing facility visits that are required to be performed in their entirety by a physician, so it's not going to include those types of services. All right, so, and so that for when you're using the time-based, the E&M visits, it's going to be based on the substantive portion is if they've done more than half of the total time. And so the distinct time is summed to determine the total time. And some examples would be, if your non-physician practitioner spends 10 minutes and then the physician spends 15 minutes, that's a total time of 25 minutes. The physician has that substantive portion. And so it's billed under the physician's information. So let's say if we have the NPP spends 10 minutes, the physician spends 15 minutes, and then they both spend 5 minutes together to discuss the treatment plan. That's kind of, that's 30 minutes, but the physician has 15 out of those 30 minutes. So that's still the substantive portion and would be billed by the physician. And then prolonged services can be reported by the practitioner who reports the primary service when the combined time meets the time thresholds. And here's a kind of a breakdown of what kind of visit code family it falls under. The 2022 kind of what is the definition of substantive portion. So you can see history exam or MDM, or more than half of the time. When we get to 2023, that turns into more than half of the total time. All right, so what qualifies as time that can be spent? So that can be the preparing to see the patient. So you're reviewing tests, obtaining or reviewing your the separately obtained history, performing that exam if it's appropriate for what you're doing, any counseling or education between the patient, family, and caregiver, ordering the tests or procedures, and then also referring and communicating, and then all of the fun stuff. And the care coordination can be counted as long as that care coordination is not separately reported in another service, like with your principal care management, your chronic care management codes. All right, but you're not able to count time on the performance of other services that are reported separately, any travel or teaching that's general and not limited to any discussion that is required for the management of a specific patient. And then on these services, you are going to use that modifier FS, the split or shared evaluation and management visit. It's because they're going to use that modifier for tracking purposes. So just kind of as an overview, also, so that is a split or shared visit is an E&M visit provided in a facility setting by a physician and a nurse or non-physician practitioner in the same group, at where incidental to services are not allowed to be reported. Okay, for the time, for the substantive portion, 2022, it can be your history exam, medical decision-making, or more than half of the time. 2023, it is going to move to, the substantive portion is going to move to being more than half of the total time spent. So they can be reported on new and established patients, initial and subsequent visits, and prolonged services. You report the modifier on the claim for tracking purposes, and then the documentation in the medical record needs to identify the two individuals who are performing the visit, and then the person providing the substantive portion is the one that needs to sign and date the medical record. So just kind of keep that as in mind. So here we've got it split for some of the critical care time, just to kind of give you an idea of kind of the time threshold. So for the other outpatient visit, the combined time for both practitioners has to meet that threshold for reporting the G2212. And remember, that's for Medicare purposes. And then if you have your inpatient, your observation hospital or nursing facility, then the 99354 through the 99359, you'd have to have the 60 minutes or greater time spent. All right, so let's go ahead and move on to critical care. So CMS is adopting the prefatory language from the CPT book for clarity, meaning that for the physicians and non-physician practitioners, you're not able to separately report several services that are listed there in the beginning of the critical care services. So just remember, the facility reporting is different. And then the updates to the critical care services is that concurrent care by more than one practitioner in more than one specialty may be covered. And that is as long as they're not duplicative services. So if you have an internist and a surgeon, or an allergist and a cardiologist, or a neurosurgeon and the primary care provider, those can all be reported separately, as long as they're working on separate items. So if a patient comes in and if they're having anaphylactic shock because they had peanuts, and so the allergist is seeing them, but there's also having some issues with their heart. So the cardiologist is coming in, and they're both providing critical care. Then both the allergist and the cardiologist can report them. So concurrent care by practitioners in the same specialty and the same group can be reported with the subsequent time code, the 99292. And the intent really is that this would be an instance where somebody in the practice is covering for another, or providing the continuity of care. But the primary provider is going to report the initial service. But if that first hour is not met, then you can use the cumulative time of the different providers. All right. And it can be reported as a split shared visit. And then also the qualifying activities are like the ones that I showed earlier in the presentation. So it's the reviewing of medical records, all of that kind of fun, normal stuff. And for critical care visits, the substantive portion is more than half of the cumulative total time in those qualifying activities. So this is a little bit different in that it's not doing the split where you could have the physical exam and medical decision making. It is going more towards that half the time, because if you're providing critical care, really you've got the high level of medical decision making. And they've also created a new modifier, FT, for unrelated evaluation and management visit during a post-op period, or on the same day as a procedure or another E&M visit. And so what this one is supposed to do is, if the patient, let's say, has had a cabbage procedure and went home, and then later has to come back in for critical care management, but maybe they've fallen and now they have a broken hip. Well, those are going to be totally unrelated. So this would be an instance where the FT modifier would need to be used. So it can be kind of tricky. So the when you have the same practitioner or the same specialty within the same group, it's not expected to happen often that you would have critical care services on the same day as another evaluation and management, but they do acknowledge that it might happen. So if you have an E&M that's provided on the same day as critical care, that E&M service has to be provided prior to the critical care service when the patient didn't provide critical care. So let's say the patient that our CABG patient, the coronary artery bypass graft patient, had come into the office for a follow-up visit within the global period, just to make sure everything was going well. It was. And so then you had sent them home. They're tootling around home, and they, trip over the dog, or they step on a Lego or something and go down and break their hip and then have to come back. Of course, that wouldn't really be critical care, would it? But maybe they knock themselves unconscious when they're going down. And so at first, the patient's non-responsive and they're not sure what's going on. So we could play what if for, till the cows come home. But I'm just hoping you get an idea of what's the differences. And so that just make sure that E&M service is separate and distinct with no duplicative elements. And then you would use that modifier 25 on the critical care services. And so also, you'd be expected to follow any like transfer of care policies and modifiers. And so so you can use modifier FT to identify when the critical care is not related to a surgical procedure, should not be bundled into the global package. But if there is any transfer of care going on, then you would go ahead and use the other modifiers, your 54s, your 55s, for your pre-op, intra-op, post-op care, all of that fun stuff. CMS did not go into every situation and list, every possibility that could go on, just so that you're aware of that and know how to take care of it. All right, and so not only were there updates to critical care, but there are also updates to the teaching physicians. And so, kind of the question was, how do you select the E&M level for a teaching physician when it involves residents who are furnishing the care? Well, the time spent by the resident is covered through the graduate medical education exemption that you get on your cost report. And so the reporting is counted as that time spent by the teaching physician performing the qualifying activities. And you can count those for selecting your level of evaluation and management service. So you would not include the time spent by the resident when they're furnishing care without the presence of the teaching physician, but you can include the teaching physician's time when present, when the resident is performing the qualifying activities. And so do not include any of that teaching time that's general and not limited to the discussion required for the management of a specific patient. So it's okay to count time. You're discussing, diabetes education with the patient. That's good, but overall teaching, the teaching time is not counted. And I'm sorry, my brain always goes to Scrubs and Dr. Cox when I'm thinking about this. So anytime that, he would spend calling JD Barbie and other things would not be counted. Okay. Now for the primary care exception, the medical decision-making is used to determine the E&M level. So it's different from the teaching physician portion. And the majority of commenters did support this proposal. Because it removes any issues of resident inefficiency. So if you've got somebody that is a little slower, and a little more tentative, it's not going to give that person, beaucoup bucks because they take longer to do it. So it is going to be based on medical decision making and not time, because the time is difficult to count when you're managing, your 4 residents and, needing to be immediately available. So I hope that is a little bit clearer than what you might have read out there in the physician final rule. All right, so the telehealth services, just the originating site facility fee is increasing to the $27.59. The updates are always released within the Medicare Physician Fee Schedule final rule. The amount is never published in the Medicare Physician Fee Schedule. So CMS now has kind of divided the services out into 3 different categories, which do not correlate to the different categories for CPT codes. But for telehealth services, category 1 services are similar to consultations, office visits, psychiatry services. Category number 2 are not similar to those on the current Medicare telehealth services list, like the office visits. But that is a service that is accurately described by a CPT code. And when it's furnished through telehealth, there is a demonstrated clinical benefit. So and then there are category 3, and these are kind of the services where the jury's still out. And so these have been added during the public health emergency because it's likely a clinical benefit when furnished through telehealth, but they don't have enough data to determine yes or no. So what happens with category 3 services is they have to be discussed, and they eventually will need to either meet category 1 service criteria, so they have to be similar to office visits, or category number 2 criteria, where it's not an office visit, but it has a demonstrated clinical benefit. So if you have comments for those, be sure to send those into CMS because they are evaluating that information. And so right now, the category 3 codes are left on the approved telehealth services list until the end of 2023. So a lot of the updates for items are going to be through the end of the public health emergency for COVID-19, or through the end of the calendar year in which the pandemic ends. But for telehealth services, these category 3 services are going to be left on there until the end of 2023. And that is going to allow for the collection of data, and they will be discussed further in next year's final rule regarding making those additions permanent or removing those. So there were 4 codes added to the category 3 list for 2022. And so these are the cardiac rehab, and they have the intensive cardiac rehab or cardiac rehab. And so then I also put on here, there's a new modifier FQ. The service was first furnished using audio only communication technology. And we'll kind of get into that within the next couple of slides. Because for the mental health and substance use disorder, CMS is removing geographic restrictions for telehealth services. Because telehealth services, you had to be within, geographically separated and within a certain number of miles from a provider, and all kinds of fun things. But what they are going to do is remove those geographic restrictions. The patient's home is going to be an acceptable originating site, which for other telehealth services after the end of the pandemic, that is not going to be the case. And so the service has to be furnished for the diagnosis and the evaluation or treatment of mental health or substance use disorders. And so it still has to be provided within the United States or the appropriate territories like Puerto Rico and Guam. So it isn't where someone can go vacation in Europe and have telehealth services. That's not going to work. So in the proposed rule, they had said that you would have to have one in-person non-telehealth visit every 6 months, but they have lengthened that to every 12 months. And then they have also said that they would do limited exceptions to that 12-month visit. And that would have to take into account, are the risks and burdens going to outweigh the benefit of a face-to-face visit? And so those risks and burdens would need to be documented in the medical record. And so, some of those risks could be that, it could cause an interruption of service delivery. It could worsen the patient's condition, or the patient's in partial or full remission and only requires maintenance level of care. So there could be differences. And I would assume, well, you shouldn't assume, but the local Medicare administrative contractors or the MACs may have their own determination of what would be a risk or a burden. All right, so the mental health and substance abuse disorder ones are going to allow for having those items furnished using only audio only communication technology. And that's because it's mainly talk therapy. And it could be that, if the patient's paranoid and doesn't want to have their, transmit through like Zoom, so there could be reasons why it's needing to be furnished as audio only. And it could be if you're in a remote area and your internet is lacking, that would be a reason why as well. Now, there are some updates to the place of service codes. So place of service 2 is going, instead of just it being telehealth, it's going to be telehealth provided other than in the patient's home. And then there's a new place of service code, place of service 10, telehealth provided in the patient's home. And so the MACs are supposed to process either place of service through the public health emergency. But once we are out of the pandemic, that patient's home is not approved as an originating site, with the exception of the mental health services, which also includes the substance abuse disorder services. And so there's a transmittal out there, and CMS said that there would be additional information coming on how the MACs would use it. But basically, because the place of service 10 wouldn't qualify for telehealth services under a Medicare benefit, they probably would not accept that as a place of service. And so we'll have to wait and see what kind of discretion is sent out by Medicare. But for other payers, if telehealth it provided in a patient's home is a benefit, then this place of service will make your day a lot more easy, or a lot easier. All right, so for therapy services, all right. So there are some updates to the physical therapy and occupational therapy when it's furnished by therapy assistants. And so there is a lower reimbursement for those. There is a new website, and I believe I have a link in the references area that provides billing examples using the therapy assistants with the modifiers. because they have identified two scenarios where the de minimis standard is not applicable. And that's where, they have to have at least meet the midpoint by the physical therapist and the occupational therapist. And then let's say the other, 6 minutes was provided by the assistant. Because the therapist reached that midpoint, then the CQ or the CO modifier is not needed. And that's the CQ and the CO is for reporting that the service was provided with a therapy assistant. So when you have an instance where the physical therapist or the therapist and the therapy assistant each provide between that 9 or 14 minutes of the same service, then kind of when you're counting the little time units, you would, in that instance, you would report one service with the modifier and one without. So that is kind of shady, but they do give us some examples. And I did use example E from the CMS website. So let's say your physical therapist spends 12 minutes of the 97110 and 20 minutes of the 97140. And then your assistant spent 14 minutes of 97110, but not on your 97140. You would report the 97140 without the CQ modifier because the therapist provided that full 15 minutes. And then for the 97110, you've got 12 minutes by the therapist and 14 by the assistant. So it kind of falls within that total time range of the 23 to 28 minutes. So you would report one unit of the 97110 with the CQ modifier and one without the CQ modifier. And so I would encourage you, if you work with physical therapy or occupational therapy, to go out and take a look at that website with the different ranges, because it can get very tricky when you're trying to do the total time to figure out, okay, how many minutes do we report with each? So it can get kind of crazy when you're doing that. So I do want to encourage you to go out there and look at that because there are more examples. All right. So for registered dietitians and nutritional professionals now may bill Medicare directly for their professional services when they're provided directly to the beneficiary. So they're kind of creating that registered dietitians and nutritional professionals can now be a provider or a supplier of service. So that kind of puts them in a different category. And so the medical nutrition and therapy and diabetes self-management training may be provided as telehealth services. And that's because your dietitian or your nutritional professionals are acting as a distant site practitioner. So you can report those specific procedure codes, the CPT or HCPCS codes, to Medicare for those. But it does not change the regulations that dietitians and nutritional professionals for patients that are inpatients of a hospital or a skilled nursing facility is included within the payment for that inpatient service or that SNF service. So just kind of be aware that if they're kind of functioning as an independent practitioner versus being part of the hospital or SNF staff. All right. So they are going to be removing the treating physician restriction. So they still have to be referred by a physician, but it doesn't have to be that treating physician. And then they've also revised the definition of the chronic renal insufficiency and changed the GFR rate that's included. All right, now for physician assistant services, this is kind of a short and sweet. As part of the Consolidated Appropriations Act of 2021, which kind of came out to help with some of the COVID relief, it removed the requirement that physician assistant services were only payable to the employer. So now the physician assistant may kind of, where it's allowed by state regulations and law, can kind of set up their own shingle and bill directly to Medicare. So it does not have to come from the employer. And so the physician assistants now may incorporate as a group and bill Medicare, but it's not changing any of the supervision requirements. So the physician assistant may form collaborating relationships with any physicians and form partnerships. But remember, it's always going to default to state scope of practice laws. So if your state does not allow for a physician assistant to kind of practice on their own, it's not going to be allowed. Unfortunately, there are still some states that are like that. All right, now this was kind of one of another update through the Consolidated Appropriations Act of 2021. They're going to update. There's an update to the coinsurance amount regarding the screening flexible sigmoidoscopies and screening colonoscopies. So let's say the patient comes in for a screening service, but then another procedure, they decide to go in and take a snare biopsy or something. And so when that additional service is taking place at the time of the screening test, then they feel that the deductible should be the deductible and coinsurance rate should not apply. So they're actually going to phase in the reduction in the coinsurance amount. So it'll take it a while to get there. But this is basically, when they discover polyps and they're taken out, so the patient isn't going to be surprised by that screening test turning into a diagnostic test, kind of to go in with the no surprise billing stuff. So basically for 2022, it's going to be an 80% coinsurance, or their 80% payment for the service, with the coinsurance to be 20%. When we get to 2023, then they're going to Medicare is to pay 85% of the service, with the coinsurance to be 15%, and that will last through 2026. And then when we hit 2027, it'll be at 10% through 2029. And then when we hit 2030, it should be down to 0%. So that is certainly, almost 10 years in the making to get down to 0%. So it will get there. All right. And so the electronic prescribing of controlled substances, this was enacted as part of the substance use disorder prevention, that blah, 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 that we all call it the Support Act because it's easier to remember. And so the Support Act mandated the electronic prescribing as Schedule 2, 3, 4, or 5 controlled substances under Medicare Part D. I know my doctor has the electronic prescribing already. They send it right to my pharmacy. It's really kind of nice. And so I think for the most part, this is being done, but the compliance is being set forth as January 1st of 2023. Schedule 1 drugs are those that are basically over the counter. And so then the different controls that are needed for the kind of the severity of the drug use is there. There is a kind of a for long-term care facilities, the compliance date is set out to January 1st of 2025 because there are issues with the different computer systems transmitting data to each other. And so they're having problems there. Set the date out so they can get those fixed. All right. Okay. So for appropriate use criteria, there is kind of a bit of a change here. So let's say the patient comes in for something, and looking at the x-rays, the furnishing provider thinks that additional services are necessary. So the first step is to try to contact the ordering professional. So if the ordering professional, they're able to get a hold of them, so that ordering professional would complete the new order, and the appropriate use criteria consultation is completed for the new order, and that information is reported on the claim. Well, let's say you're not able to contact the ordering professional. That's where the changes come in. And so then the furnishing provider may elect to provide those additional services according to the guidelines in the benefit policy. And in this instance, the appropriate use consultation is not necessary. And you would use the information from the original consultation on the claim. But CMS is expecting this would be an unusual circumstances. That would be an unusual circumstance. And they are going to be monitoring for not adhering to the benefit policy manual requirements. And they have extended the effective date for the penalty phase to January 2023, or the January following the end of the public health emergency for COVID-19. All right. And so just kind of they're, limiting the AUC programs to outpatient prospective payment facilities with that bill type of the 013X, also professional claims. And then they are going to create a new modifier for instances where that ordering professional is not required to report the AUC consultation. They have not created that one yet, so it will be probably in the next final rule. All right, so for pulmonary rehab, they are taking comments on direct supervision and whether they should keep it as the audiovisual. And so they would address those later. The G0424 has been deleted and replaced with the 94625 or the 94626. The 94626 CMS feels will be reported almost 100% of the time. And so some changes to the individual treatment plan, that it may be established, reviewed, and signed by the medical director or any staff physician in the program that's involved in the patient care, or by the patient's treating or referring physician. And they're also expanding coverage. So people have been hospitalized with COVID-19, and that could be confirmed or suspected, and they are experiencing persistent symptoms for at least 4 weeks after the hospitalization, and that can include your respiratory dysfunction, or what we're kind of calling, your post-COVID condition, long haulers, long COVID, those types of things. So the patient, so if the patient did not need to be hospitalized, but they should have a COVID-19 test is not required, but must have confirmed or suspected COVID-19, and that they are having those persistent symptoms, that is including respiratory dysfunction for at least 4 weeks. And they're counting that 4 weeks from the beginning of the symptom onset. And so they've also changed some of the regulations to align the cardiopulmonary and intensive cardiac rehab. So it wasn't anything that was outrageous. So drug pricing and payment. So manufacturers without a Medicaid drug rebate agreement are supposed to report the average sales price information to CMS on a quarterly basis. And CMS has defined the drug to include any item, service, supply, or product payable under Part B as a drug or biological. and it should be reported by NDC code or the supplier's product identification number, and that does not, and it does not exclude repackagers. And so they're kind of calling this under the 505(b)(2) drugs, and that could be a multiple source drug code, but currently assigned to a single source drug code. So the concept is to pay similar amounts for a similar drug, and to calculate, CMS is going to calculate to get the lesser of amount. So they'll calculate the average sales prices, including self-administered drugs, and then they're going to calculate the ASP and remove the self-administered drugs, and then use the lesser of amount. And this really started with the Cimzia and the Orencia, because those can be self-administered. So what they're going to do is review the average sales prices and then pay the lesser of. And the COVID-19 vaccine administration is going to remain at $40 until the end of the year that the PHE ends. They are still going to go ahead and do the in-home add-on payment of $35.50 until the end of the year the PHE ends. And then after the public health emergency, the administration is going to drop to be around about $30. So about what other vaccine administrations are. And the monoclonal antibody treatments are going to be covered under the Medicare vaccine benefit through the end of the year, that the public health emergency ends, with the administration of $450 in the office or $750 at home. And then after the PHE, it'll be treated as monoclonal antibody therapy. So it will kind of go to a different benefit category. And let's see. So skin substitute updates, and this is only going to apply to physician offices. There is a C1849 for your skin substitute synthetic, but that's only for facility use. And CMS is going to create Q codes for some synthetic skin substitutes that physicians may report with the skin graft. So that's your 15271 through the 15277. So watch out for some new product specific skin substitute codes. Currently there are some A codes, A2, and there are about 10 of them, where the initial procedure is probably going to be done in the facility, but as the patient heals, they would be coming into the office. So there would be some debridement done to kind of get rid of the old skin, dead skin tissue, and then a reapplication of some of these skin substitutes like Novazorb. And so kind of watch out for those, because what CMS wants to do is kind of streamline how those are reported across the facility, the ASC, and the physician office setting. So those will be some updates. And a new modifier, FR, that the supervising practitioner was present through the two-way audio-video communication technology. The modifier came out. I have not seen any guidance on this at all. It's just that, hey, it's in the file for the modifiers. So that is available for use if that applies to your situation. And so the merit-based incentive payment system, they discussed a lot of information, and what they're going to do is kind of revamp it so that they can move to digital quality measures by 2025. They are so that your information can be transmitted to CMS and you won't have to pull a bunch of measures out. And so they are requesting comments. And so they are going to use the FHIR standard for the current electronic clinical quality measures. And the goal is to ease the reporting burden and associated costs. And so they're going to try to leverage and advance standards for digital quality or for digital data, and try to obtain it all through the electronic health record, and then also to redesign quality measures to be self-contained tools to help better support data aggregation, and also to align measure requirements across reporting programs, other federal programs and agencies, and even the private sector. All right, and the last slide here. Woohoo. Last Friday, the Protecting Medicare and American Farmers from Sequester Cuts Act was published. And so the pay-as-you-go sequestration of 4% was eliminated for 2022, which doesn't mean much because it's really not used. But the budget neutrality adjuster was changed from a 3.75% to 0.75%. So that should make the conversion factor change from like 33.59 up to 34.62. However, CMS hasn't published anything yet. So I'm still kind of waiting to see what that comes out, because also the sequestration was set for a 2% decrease, and they've kind of delayed that. So January 2022, there will be no sequestration decrease, but April 1st, they are going to put in a 1% decrease. And then for July and October, a 2% increase. The radiation oncology model implementation was changed to January of 2023 to give another year for getting used to that. And then some of the Protecting Access to Medicare Act regulations for reporting laboratory payments was delayed for another year. And guess what? That takes us to the Q&A session.
Okay, well, we are almost at time. Ardith, I don't know if you just want to answer maybe one or two, and then we can do the Q&A doc
Sure.
afterwards. Okay. So I'll just do this first question. Shared visit, oh, it's a comment. Shared visits are allowed in the facility setting under CMS regulations. That was a comment. Okay. So first question, a provider-based practice that bills with POS 22 or 19 may not bill incident to per CMS. Has that changed?
That is kind of the bugaboo in the room, and nobody has said anything. And so that's kind of what makes it difficult, is that there hasn't been any information really coming out saying one way or the other about provider-based departments. And so that's kind of where I'm taking that sentence that says where the incident to is not permitted to mean that it's the inpatient setting that is meant by the incident to is not allowed, because, we've all been doing the split bill where it is incident to. So that does kind of make it difficult. I was able to attend the CPT symposium, and somebody asked that question, and the CMS subject matter expert and 3 MAC medical directors wouldn't answer it. So I have the impression that the MACs are trying to determine how they're going to apply it as well.
Great. It looks like a lot of people are having to jump off right now, and we are at time. So for everyone that's still on, what we will do with the rest of the questions is we will create an FAQ document with all of these questions and answers, and we will post them on our webinar page as soon as we get to them. Ardith, do you have an idea of when we may have that posted? I know it's busy with holidays coming up.
Yeah, I will try to have it out, let's see, by next Wednesday, but we're still waiting for like the Medicare Physician Fee Schedule, RVU file to be published, and all of that stuff. So I will do my best to get it out by next Wednesday.
Great. So if you have one of these questions, maybe check back before the holidays. It should be posted on the website. And like I said earlier, the AAPC CEU certificate and the link to the recording and the slide deck will be sent out by end of day today. And if you don't receive it, just reach out to us tomorrow morning. And I think that's all. Everyone have a great rest of your day and happy holidays.
All right. Thank you, everybody.
Thank you.